Hey, it's Rebecca. Welcome to the Brainy Blonde podcast. I'm glad that you're here. I'm so grateful that you're here. And I know that all the people who listen to this podcast are going to be so excited to hear about what you are offering as a treatment in Germany.
Yeah, it is time to move on, I think, because with the standard of care, we have not solved the glioblastoma during the last 20 years. So the first study from Roger Stupp came out in 2005. We are 2025, already 2026, and the standard of care has not changed, although the insights in the molecular biology and the tumor biology of glioblastoma has changed a lot and has improved a lot. But getting the translation of insights in new standard of care, that seems extremely difficult. And I think that was the reason why we have said, no, we don't contribute anymore to the standard of care. We try to think, what can we do more than the standard of care in a rational strategic plan in order to get control over disease. And of course, to do that, you need the appropriate legislation that allows you to treat patients on an individualized basis, and that is the reason why we can do such efforts here in Germany. And I think if you do such efforts, then you have also to communicate to the peers in the field, but also in layman language to the patients in the field, what you are doing and what your results are. And I think in this way, your podcast initiative is, of course, of utmost value to communicate to the patient community where we are right at the moment.
Yes, that is you've already said all of the things that I wanted to ask you. Why Germany? Why are all these brilliant minds going to Germany? And you're talking about the legislation that allows for personalized cancer treatment in that country.
Yes, we have published that in 2024 in one of our review publications, this note of the legislation that is needed to do such a pioneering explorative work. People who are interested can read it in a publication in 2024.
Link that. I'll find it and link it.
Yeah, I can send you this publication. It's on my list of published papers.
Wonderful. Yep. Well, yeah. So will you tell me about what it is that you do and how it works?
Well, this I compare it a little bit with the war against cancer. I think it were the Americans who have made this term, the war against cancer. But if we look how the military people are setting up a war, they try to take out the essential structures of the enemy, and then they send the ground troops, eventually supported by the Marines, to get the local control, and then they have to maintain the control because the enemy will, of course, try to move. Well, that's one of the elements that we have also tried to set up in glioblastoma war. First of all, this is a very highly dynamic tumor. This tumor really moves and changes day by day. So we have not a controlled enemy, we have an uncontrolled enemy. And we have first to get the enemy down as much as possible in the first phase, which we call the anti-cancer phase. And then once we have done that, we have to send our ground troops to keep control because the enemy will try to change. So this control must be locally strengthened. And finally, we have to get the whole situation under control so that if the tumor goes to the left or goes to the right, you have to cut it down immediately, and you have in fact expand your protection umbrella broader and broader. So that's the reason why we have developed the concept in 3 phases. It's not seen in glioblastoma treatment that you have a first phase, a second phase, and a third phase. But the first phase is the standard of care. No way neurosurgery is the number one.
Yep.
Eventually now we can already give one checkpoint inhibitor prior to the neurosurgery with the aim to change the inflammatory response in response to the neurosurgery. That's the neoadjuvant Keytruda that is given by some doctors already. So that has a particular goal, strategic goal. And then, of course, you do your neurosurgeon, that's an atom bomb, getting your enemy out as much as possible. And then you go to your second local therapy, the radiotherapy, strengthened by the temozolomide. And then you go to your maintenance treatment, usually temozolomide, but sometimes, meanwhile, lomustine plus temozolomide in cycles of each 4 weeks. And if it is lomustine, temozolomide, it is in cycles of each 6 weeks. So that's your first standard of care. That's your anti-cancer package. But one can ask, if you have such a complex dynamic tumor, is the control with one or two alkylating chemotherapeutics in fact enough? And if your tumor is MGMT promoter not methylated, then the tumor is able to produce the enzyme MGMT, and the enzyme MGMT will correct the damage of the chemotherapy, also of the radiotherapy. Is that enough? Everybody feels it's not enough. So we have to do something more already at this phase. And that something more, what we do is the addition of the injection of Newcastle's virus.
Okay.
This is an oncolytic virus that also kills cancer cells, similar to the chemotherapy, but it's a biological therapy. And we also give modulated electrohyperthermia. These are electromagnetic waves in the domain of the megahertz frequency. A lot of people know the tumor treating fields from Novocure. These are electromagnetic waves in the kilohertz, so slower. And if you give these electromagnetic waves in the megahertz, then you give a selective heat stress reaction to the tumor cells, because the conductivity of these electromagnetic waves in the tumor cells is different as compared to the healthy cells. That's why the tumor cells have a selective heat stress, and again, they die. So now we have the chemotherapeutics and the tumor cells die. We have a biological therapy and the tumor cell die, oncolytic virus. And we have a physical therapy and the tumor cell dies. But there is much more. In contrast to the chemical way of tumor cell killing, the biological way of tumor cell killing and the physical way of tumor cell killing occurs in another modality. So the way the tumor cell dies is completely different, because there comes an immunological danger. That means that now you have dying cells, you have released free virus, and you have an immunological danger signal. That is the situation where the immune system becomes alarmed about the situation. That's why we call the combination of the injections of oncolytic viruses and the sessions of modulated electrohyperthermia, we call that immunogenic cell death. A cell is dying and the immune system becomes alarmed.
Okay.
And what will happen? The dendritic cell will pick up the broken tumor cells, the antigens, and the virus particles, and will start doing the normal job of a dendritic cell. That means go to the lymph nodes, become a mature dendritic cell, and present nicely the material to the immune cells and give them the activation signal to the immune cells. And that's the way how we get activated immune cells against the tumor antigens and against the virus. And these immune cells will already start fighting against the tumor antigens, tumor cells, and fighting against the oncolytic virus that only infects the tumor cells. So with the combination of the chemotherapy and the ICD immunotherapy with oncolytic viruses and modulated electrohyperthermia, you have a better immune control with 3 mechanisms instead of 1, and you already start triggering the immune system, that the immune system becomes aware that something is going wrong there. But you do even more in this phase by combining the 3 modalities of tumor cell killing. With the oncolytic virus and with the modulated electrohyperthermia, you also kill glioma cancer stem cells. And you do not do that with the chemotherapy and not with the radiotherapy. So you also start to fight against the source that triggers and gives always new tumor cell clones. And that's, of course, an extra interesting element. And by combining the chemotherapy with the oncolytic virus and the modulated electrohyperthermia, you also start changing the tumor microenvironment so that your immune system becomes, your tumor microenvironment becomes more accessible for the immune attack. So this first phase of chemotherapy plus oncolytic virus plus modulated electrohyperthermia does much more than just 3 modes of tumor cell killing. You really change the complete tumor biology within the tumor. And you need the 3. I have a lot of patients who ask, why should I take temozolomide if my tumor is MGMT promoter not methylated? I'm not sensitive to temozolomide. No, I say you should. Because this is exactly the change in the tumor biology that we have to try to reach. And even the temozolomide and the radiotherapy at that time point will induce, to a certain extent, more tumor mutational burden because they work over the genetic mechanisms. But having this increased tumor mutational burden, you have more tumor antigens and you are a better recognition system for your immune system. So there is a real synergy between the standard of care and already the first phase of your immunotherapy. The oncolytic viruses, the modulated electrohyperthermia, the immunogenic cell death immunotherapy. And of course, once you have done this first phase, you're not done. You have now a major reduction of tumor cells, but they are maybe with a little bit higher tumor mutational burden. But they are more visible for your immune attack and you can penetrate them better. So that's the moment where you have to start your vaccination. That's the second phase, is the immunization phase with vaccines. You have actively to stimulate your immune system against the residual tumor cells. I say the residual tumor cells because they are already changed as compared to the initial tumor that has been operated before the radiotherapy and before the chemotherapy. These are already other cells with other mutations, with other antigens. So that's why in this immunization phase, we create our dendritic cells out of the blood of the patient. That's our carrier. As an antigen, we give again the oncolytic virus and the modulated electrohyperthermia. We again kill cancer cells and the fragments, which we call antigenic extracellular microvesicles or apoptotic bodies or large oncosomes. At that moment, they are released in the blood and we can pick them out of the blood and load them on our dendritic cells. So we have in our carrier now the antigens that are in the brain right at the moment of production. A carrier, an antigen, but the vaccine needs also a danger signal. So that are the 3 components of a vaccine: the carrier, the antigen, the danger signal. Well, the danger signal we give in the laboratory. Then we are sure that our vaccine has received the danger signal and we can measure in the quality that the dendritic cell has received the danger signal. We give cytokine cocktail and we give also Newcastle disease virus because that's an extra antigen. And that is the way how we produce the vaccine. That is then a procedure of 8 days for this cell culture, and then the dendritic cell is injected intradermally, so within the skin, in the arm and part in the ear, where we think that then the dendritic cell moves at best to the lymph nodes to do the normal job. What a dendritic cell has to do, go to the lymph nodes, stimulate the immune cells, and the immune cells have to fight against the cancer. In the immunization phase, we give 2 times such a dendritic cell vaccination cycle of 8 days with an interval of about 3 to 4 weeks.
Okay.
And then we have finished our immunization phase in our global therapeutic strategy. The tumor does not go in retirement. The tumor will try to escape the immune control. That's a known scientific term, the tumor immune escape mechanism. Tumor cells will try to downregulate the antigens through which they are recognized. They will generate new subclones if still glioma cancer stem cells exist. They will modulate themselves to escape the immune control. So we have to expand this immune protection and to counteract immediately these new tumor initiatives. And that is the reason, and I think this is really important, that we give this maintenance immunotherapy with 5 days immunogenic cell death immunotherapy in the beginning each month, and then later on in a lower frequency that is decided patient per patient, but you should persist in killing new initiatives of the cancer in a way that the immune system learns more and more antigens to which they have to get the control realized. So these 5 days, I see these therapies on the long run have the aim to keep the immune control and to expand the immune control. Of course, the immune system has a little bit to be helped in that. And there we come with another modality of immunotherapy. I've already spoken about immunogenic cell death immunotherapy, the oncolytic virus and the modulated electrohyperthermia. I have spoken about vaccination. This is active specific immunotherapy. Now we come with modulatory immunotherapy. Modulatory immunotherapy will try to facilitate the immune action against the cancer. Already during immunization, we know that we have to use one checkpoint inhibitor to get a better activation of the immune cells. And in the maintenance and expansion phase, we use other checkpoint inhibitors with another goal. Now the goal is that the T cells should not become exhausted by doing their work. So also in the global strategic plan, you need to use your checkpoint inhibitors aimed for the goal that you want to reach.
Right.
And that is why we give an anti-PD-L1 during immunization, and that we give an anti-PD-1 and an anti-CTLA-4 in low dose during the maintenance phase of our global strategic plan. And then to further expand the immune protection in this third phase, we have some long peptide vaccines that we also give to the patients, for instance, against UT1, because that is also a little bit working as an anti-angiogenesis. And if P53 is playing a role in the tumor mutations, then we know that most likely a molecule called survivin, the Schirrmacher is also under study. Well, this molecule survivin is then upregulated, and we have also a long peptide vaccine against survivin, because then we have this more generalized protection. So we have different phases in our war against cancer, and you can compare it. If we do it in this way, we know the tumor blocks the immune system. So first phase is reduce the tumor volume. Second phase is stimulate the immune system so that the immune system can block the tumor. Third phase, the tumor will try to escape the immune system. So in the third phase, border the new initiatives of the tumor. And that we do with the addition of different modes of immunotherapy at the different phases in combination with the standard of care. Immunogenic cell death immunotherapy, active specific immunotherapy with vaccines, modulatory immunotherapy with different types of modulatory immunotherapy, and that all is connected to each other and has a meaning to each other and supports the effect of the other. And that is our strategy. And then I have told you half of the reality, because a glioblastoma exists about half of tumor cells and half of non-tumor cells. So that means you also should have an eye on the second half, the non-tumor cells. So there are, and that is known by Hanahan and Weinberg, the big publications on the hallmarks against cancer. We have to focus on different extra domains in the tumor biology. I've already mentioned the glioma cancer stem cells, the effects of the hypoxia, the inflammation, the metabolic dysregulation of tumor cells, the neuron glioma axis, the electricity of the neurons that support the network of the tumor, the psychoneuroendocrino-immunology axis, the gut-brain axis. They all play a role in the tumor biology, and we have developed and published a whole cocktail of repurposed drugs that can be combined and that can somewhere influence these domains in cancer, making your real battle going better. I compare that sometimes with the Olympic Games. The Olympic Games, you have 8 people standing here and they have to run 100 meters. And the one who has run fastest, he gets the golden medal, go home and is the hero. The Olympic game is nothing more than be the fastest, get the golden medal and be the hero. That's the anti-cancer battle. The surgery, radiotherapy, chemotherapy, different types of immunotherapies and so on. But of course, the Olympic Games are much more than the golden medal for this one fastest runner. There is the opening ceremony. There is the public that supports the runner. There is the quality of the floor. There is maybe the wind a little bit in the back. The public does not run the distance. The runner runs the distance. But the public can facilitate the runner. So all these repurposed drugs, we should really say to the patient community, they do not cure cancer.
Right.
But they help that your treatments work in an optimal way.
Yep.
And they focus on domains that you get in a better way to get your war won with your agents. And that is how I try to convince the patients, on the one hand, to follow the standard of care and the immunotherapy on top of that, and at the same time to do all these complementary medicines, the repurposed drugs. And if one is not tolerated, that's one less in the public. That will not make a big difference. But both somewhere have their own role. And indeed, the runner can rush the distance without public, but it's much more fun if there is public and if there is a good environment. And that is how we give the global therapeutic strategy against the glioblastoma, but on the other hand, also give all these domains, all these repurposed drugs that we also suggest to the patients to take that.
Wow. So you're really hitting them with everything. I mean, you're really doing everything that I've ever heard of in terms of glioblastoma warfare, and recovery is on your radar. And it really sounds like you're encouraging everything. Now, I'm not a really science-based person. I think I understand most of what you've said. What I've heard in the past, let me just make sure I say this right, is that if you do too many things, and then glioblastoma tends to want to hypermutate and continue to change. And so you're chasing a moving target, so to speak. And what you're providing is, rather than using that initial surgical tumor tissue and continuing to treat what was there at that point, by taking the liquid biopsy or the blood, looking at what's there now, you're able to chase the moving target, so to speak. Am I getting that right?
Absolutely. That is extremely important. We have to do with a dynamic tumor that changes. Indeed, people are sometimes surprised when I say I'm not interested in your tumor tissue. They feel shocked. He's not
Yeah.
interested in me. No, I'm not interested in this old tumor tissue. I'm interested in you, in your tumor at that time. And that is, of course, something very innovative. But honestly spoken, I had written in 2018 first publication of our results here, and I had an old man from the UK who came with me. There was a very, very special man. He bought science journal for me. So he was really, really involved. And he said to me, I think that instead of using this old tumor lysate, you should continue with this liquid biopsy for your therapy for the yield of your antigens, because I think these patients do better. So that was already visible in 2018 for a 70-year-old, but very, very clever UK patient. I was really surprised of this man. I never forget that. But I think he's right, and I think the 104 patients that we are now trying to publish. So it's right. So we really gain life months by doing this global concept. And as said, each element has an own role in it. We published in 2022 that, because some patients have asked it, only do radiochemotherapy and then no maintenance chemotherapy, but instead only immunotherapy. I've done 7 such patients and I saw it's not good.
Okay.
And I've immediately published that because this synergy. So in fact, we profit from the failure of the temozolomide, ending up with tumor cells with higher mutational burden because they are more recognized by our immune system. And we have changed the tumor microenvironment at that time point. So really, we profit from the intelligence of the tumor to get that as a weakness in the tumor. And that's really trying to think in this war against cancer with the global treatment strategy. If the enemy does this, then we can do this.
So you had 7 patients that you tried. They didn't do what we call it the 523 chemo, the maintenance chemo, and you saw flat out that is not as effective with the treatment that you're using. It's better for methylated, unmethylated, doesn't matter.
Yes.
It's still better with the treatment that you're doing to do that chemo.
Yes,
this is so important for me to know.
Yes, that is a real important information because it happens several times that I really have to convince the patients in the strategy. Even if your weapon on the first glance looks weak, in the global strategy, it might be essential.
Yeah, that makes a lot of sense. So for the people who are listening now, if they're fighting glioblastoma or their loved one is fighting glioblastoma, at what point can they jump in and reach out to you at any point, or does it have to be immediately upon getting diagnosed? How does that work for the person who is in this battle?
We at best receive an email with a summary of the disease history and the treatments given till then. It is the reality that not all patients find us right from the beginning, but somewhere during the maintenance temozolomide or lomustine temozolomide, we can jump in.
Okay.
If that is already after the first, that is of course better than if that is after the third or the fifth. But somewhere we can jump in and already do what we try to do. So in the most ideal way, we become informed quite early in time. Then first of all, I can relax the patient that we know this stuff and don't panic at the moment. We are still on track. Then we give the instructions. So about 2 to 3 days after the first course of the maintenance chemotherapy, we have to see the patient then in Keulen for the immune diagnostic procedures and the first 5-day ICD immunotherapy. And that then works, then they are on track, and then it's no problem. So the sooner they contact, even if they should not come immediately to us, the contact is already there, and they know, okay, they immediately get from me a number because that's in my database. I know then immediately about who it is, where we are, what is the issue, and then we can follow that up on a distance. And once it's time, then I say, now you have to come.
Okay. And then they come to Germany, they fly to
Yes,
Germany, they get the treatment with you in Germany.
yes.
And the first time, I think you said maybe it was 8 days the first
Two,
time.
no, no, the first time so is 2 to 3 days after the first chemotherapy course. They come to Köln for the first 5 days ICD. And then each time chemotherapy course, 5 days ICD.
Oh,
Again,
okay.
therapy course, 5 day ICD. Again, therapy course, 5 day ICD. And that runs as long as it runs. That is decided by the local oncologist. If it is an MGMT promoter methylated patient and the patient tolerates the chemotherapy, one can easily go to 12 cycles of temozolomide, for instance. And then once all the chemotherapy cycles plus ICD are done, then we start with the second phase in our treatment strategy. That's the immunization phase. And then there are these 2 8-day DC vaccination cycles with 3 to 4 weeks interval.
Gotcha. Okay. So 2 times for 8 days,
Yes.
again with a
And
3 to 4 week interval. Okay.
yes, and then we start with the third phase.
Mm-hmm.
Then it are again 5 day blocks. And the frequency of these 5 days block in the third phase is depending on the response to treatment, the residual tumor, and the feasibility of the patient, of course. If you have no tumor at all, then you are quite relaxed. But if you have real tumor burden and just under control, then you are very prominent there to keep it under control. So that will be decided individually.
Yep. Okay. So are you still seeing any patients that you saw back in 2018 or 2022? I mean, how has this been going as it evolves?
Yes, so the patients that do good, most of them persist in coming, for instance, 2 times per year because they
Okay.
feel good. I always say stopping a therapy is more difficult than starting a therapy because if you stop a therapy where you feel good with and it's manageable and it's organized in your yearly life, then I
Yes.
say you should not anymore come. Then say, oh, I come.
Yeah.
So, and that happens. Yes, that happens. So we have several such patients, yeah.
Okay. So there is an opportunity after everything's under control, you're having stable scans, you've finished all 3 phases with you, and then there's this maintenance of 2 times a year coming back, would it be kind of a
Five
booster or
days.
something to keep it, just to keep your
Yeah,
immune system recognizing this, to keep the tumor stable or not from no recurrence? That's the
yeah.
ideal.
That's the ideal situation.
Okay, this is so good for me to know. So this is very glioblastoma specific, correct? Or is it all brain cancer or glioblastoma specific?
Well, no, so we are also looking to diffuse midline glioma. That's are
Okay.
the histone mutated tumors. It's much more difficult. We have also a long peptide and a short peptide against the H3K27 mutation. I think for some patients, at least, we make a difference, but cure is there much more difficult as term to be used. But
Mhm.
I think some patients we can prolong life with a good quality of life. And then you have the diffuse hemispheric glioma that has the G34 tumor. There we have also at least one patient, it's a very, very rare tumor, but we have one patient who is now, for instance, 3 years or 4 years maybe, meanwhile, completely out of disease. There
Wow.
a proof of principle. This young girl had to stop her master studies and is now considering to restart her master studies. She has, of course, a little bit problems with speech and so on, but the university seems to be flexible in organizing exams adapted to her restrictions in her physical being. So that would be, of course, a huge success story if after
Yeah.
such a brain tumor attack, she can go back to university.
Yeah,
So
that's
so it is
incredible.
all, yeah, but there we learn that if you do nothing, you gain nothing. If you try in an honest way, you might gain something. That
Yes.
is, in fact, what we learn. What is maybe also important for your patient community, since October 2021, we do a fanatic quality of life measurement. And
Ooh.
now we are releasing the first data that the quality of life of our patients under this nevertheless complex treatment is very well. So we use in international created scale, which is translated in many languages. This is a patient-reported outcome measurement. So the patients fill that in here in the waiting room at time of each course. Now we have long-term follow-ups of all these documents, and we see indeed that the quality of life is very acceptable, is in fact, I think, not affected by even the fact that they have to come to Köln, that they have to be here. And I think that's also an important element. We claim that we prolong life, but now we document that we prolong life with a good quality of life.
Yeah, I love that you're doing that. And I feel like that's so important. It's so important to speak to that. It's not just how many years, but how good they are. And I know so many of us are frustrated in the US because I talk to people internationally as well, but at least in the US, the UK, some places, it doesn't seem like the team really listens to that part of things for you and just treats the disease and not the person. So quality of life is huge. And so many of us want to feel empowered that we're doing everything. It's okay that it's hard. It's okay if we have to change our diet or take a lot of medicine or travel or even spend a lot of money to do these things. Just give us a chance. And so I appreciate that you've looked into that as well.
Yeah, I think that it becomes mandatory. But for me, it is also mandatory to get that documented. And I said we have taken in 2020 a huge initiative because how to measure quality of life is also not so easy. And we have to do that independent from neuropsychologists and so on. So we needed, and this is an European scale of quality of life that has been really developed in a patient-reported outcome system, where you also have the norms in population. So we also can calculate the health utility index, and then we even can go once or in health economics, what is the cost effectiveness and so on. So this is all information at the backside, I would say, for the moment. But if we don't start measuring, we will not know it.
Absolutely. Yeah, you can't just hear these anecdotal stories. You're actually doing a scientific method to track the quality
Yeah.
of life as well, which
Yeah.
is
And
very unique.
yeah, and I don't understand. So I will discuss that in the group of quality of life in the pediatric neuro-oncology, where I have to present in March in Rome. There is no, or not that I find in literature, longitudinal quality of life measurement. You have then once a quality of life in the beginning and then once after 2 years. But what happened in between?
Yes.
In our system, we know it month per month how it goes.
Yes. That's so true. That's fantastic. Are you when people come, are they inpatients? Are they staying just kind of locally and in and out of the clinic? How is that happening?
We do not have hospital beds here,
Okay.
so it is mandatory. So the only selections that we have to do is Karnofsky index should be at least 60, 70. If there's a wheelchair patient that needs a little bit help for moving with wheelchair because patient has not yet learned it, him or herself, that would be Karnofsky index, but the patient should be good enough to come to Köln, and then indeed traveling to Köln, repetitive traveling to Köln, and staying in Köln for ambulant therapy. That are the real requirements that are essential. So we should not take risks in transport. We should not take risks in staying here. We have some locations here in the surrounding apartments and hotels. They know that this is an IOZK patient, and if something goes wrong, they phone us and so on. But it should be safe and in an ambulant setting.
That makes a lot of sense. And children too, pediatrics and adults?
Yes. So as my background is in fact pediatric neuro-oncology, I can also do children. So there are some medulloblastomas. It's not my first target for immunotherapy, but still we have some children with medulloblastoma that come. So certainly the MYC positive medulloblastomas from the group 3. There is some impression that immunotherapy helps in controlling this more difficult group of medulloblastoma. Yeah, some ependymoma is more difficult. Childhood, that seems more difficult.
Fair. Okay. All right. And then are you having a lot of resistance with getting teams on board, medical teams on board with supporting patients? Are they just doing it without really consulting their teams? Are you having a lot of collaboration?
Well, yes and no and yes.
That's a hard question, I know, but
So there are phases. So when I was at the university, then I had a remarkable support. So they found it really a brilliant idea. In the beginning, they did not believe, but they saw the results. So I have treated the first glioblastoma in Europe with dendritic cell vaccines. So I have the longest experience per definition. And this patient was already published in 2004. And people saw, yeah, what's happening here? This crazy man starts thinking on immunology in the brain, but the brain is an immune privileged milieu. There, the immune system does not come in. And I said, no, we have to do immunotherapy for brain tumors. So in the beginning, there was a little bit unbelief, but they saw the effects. And even there is one or two patients from the very beginnings before 2005 that is still alive today. So really, and that were relapse patients at that time point. So there was an enormous positivism, but once I discovered these dynamics in the tumors, I have to change my protocols and follow the tumor.
yes.
But then that seemed not anymore to be science, because in science you have fixed protocols. And I said, no, we cannot use fixed protocols for dynamic, uncontrolled tumors. So, and there I came in conflict with the university. So then all the support was away. I was a loser, and now I am 10 years here at the IOZK. I am starting to develop the concept that I have depicted, which can never be studied in a randomized controlled trial. Never. But my patients ran around on the street. Yeah, that's of course also a little bit the problem. The patients are convincing again the doctors and show, look, what he is doing, I'm still here alive. So the patients now help that the community comes back and comes in contact with me, and now it is again improving. That's why I said yes, no, yes.
See, well, and that's what I'm seeing. That's how I got to meet you, because I've talked about the treatment that I got and that I've lived. And gosh, I wish I knew you were out there in 2004. That's when we lost my mom to glioblastoma. So I know how the care didn't change from her to me, and which is why I went and I did a different treatment in Germany. But I have so many people reaching out to me and saying that I need to talk to you, because the testimonials, right? People are still here and they're saying, you need to tell people about this treatment too. This is so fast. It's so much to wrap my mind around. I know it's going to be a lot for people to hear the scientific terms. It's a challenge, but I think you explain it so well. I love that you're going to battle analogy. You really, because I really like to think of us as warriors. I always like to use empowering language as well. But you can just see how many facets there are, and that when we're talking about, we're acknowledging the fact that the tumor is constantly evolving, and that is exactly what your treatment is designed to do. And that's exactly why a randomized control trial doesn't work.
Well, but that's of course the big problem. And there the community will have to help again, because of course insurance companies, they say we need randomized controlled trials with a placebo arm or something extra with the control arm. But in a randomized controlled trial, if the enemy is not controlled at all, and if the immune system reacting on radiotherapy and chemotherapy is not controlled at all, how can you do a controlled trial in uncontrolled situation?
Yes.
And I'm asking that to my peers, and I don't get an answer. I have really depicted a road turning to the left, and it's a reality. I was learning the boyfriend of my third daughter driving the car. And he was driving, and there was a land road going to the left. And I said, you should go to the left. And then I discovered, but if my tumor goes to the left and my protocol goes straight forward, my car will crash. That's what we are doing day by day. We are doing day by day this, and we are so. And if we say the relapse, the progression-free time is so long, and that's due to my treatment, no. That can also be that you have by accident a tumor that is slower in moving, slower in dynamics, and that you don't have under control. And so I'm wondering whether for such a tumor biological process as glioblastoma, whether the traditional clinical research methodology, phase 1, phase 2, phase 3, is in fact appropriate. The answer is in fact already no, because we have not made any progress in 20 years. Whatever we try, we don't reach our goal, but maybe we do not reach our goal because our clinical trial method is wrong. The concept of randomized controlled trials is outdated. It is from 1948. Sir Bradford Hill has discovered this methodology. We have not adapted and we still keep it as the only holy grail. For most diseases, it's okay, but maybe not for highly dynamic tumors like glioblastoma. Maybe there it's not okay. And then we have to start to acknowledge other observations as a high enough level of evidence of efficacy. And that's, of course, a very big battle with insurance companies and so on. Also with some scientists who only want randomized controlled trials. But I have given an interview in the International Union Against Cancer in Melbourne, was in November. I've asked there, help me. How can I deal with this problem? Nobody finds an answer. They all believe in personalized medicine, individualized medicine. But if it comes onto money, where is the randomized control trial?
Yeah.
It is as it is.
It's exactly right.
But that's a problem for our patients because the costs are at the level of the patient because the insurance companies say it's not randomized controlled.
Right.
And the problem is the patients stay alive. So
Yeah.
it costs more.
I hate that you say that, but you're right.
Yeah, I have literally had a person from the insurance company who said, because your patients stay alive, we cannot pay.
Yeah. And there is no end. I mean, we don't know, even if, they continue to do well, you have to continue to treat. It's not like, and now we're done.
Sure. And if then there is a little bit disability and you need your anti-epileptic drugs and so on. So these costs remain. So it's better that the patient does not stay alive.
Right.
So and that's of course at another level and maybe not for the community right now, but that's the battle that I have also to play in how to deal with the organization of such novel treatment complex that cannot be studied, but in real world data. That's also a new term, real world data and health technology assessment. I think these are other methods to evaluate eventually level of evidence, and that is a big issue, and I think at the end the patient community will have to fight for it.
Yeah, I agree. Yeah, this isn't something black and white. This isn't something that can be proven in the way that it's had to in the past. So the standards are going to have to change. And I just had a young mom call me a couple hours ago, a different type of cancer her son got, and I didn't know that much how to help her, but she's like, what is wrong with the system? Why isn't there something better? Why isn't it changed? And I think you just spoke to it so clearly. We don't have to say there's evil or there's some malicious intent. It's just very unclear. And we can't keep doing it the way we used to if we want to do better.
Sure. And that is there we need the efforts at all sides to get the community convinced. But as said, slowly but certainly I see more and more colleagues referring patients that they may be on demand of the patient. So there your role is of utmost importance, is the visibility. So many people say, I'm so angry against my doctors because they don't have told that to me.
Yeah.
That's something which nowadays is in fact not anymore completely correct. They can say, I don't believe in it. It costs enormous of money, but at least then the patient can look to it and can take the autonomy to decide whether the patient wants yes or no. Still, even I live in the time where patients have doctors who say, if you go there, I don't treat you anymore. That's not allowed. That's not allowed. The doctor is not the emperor of the patient. The doctor has to help the patient, has to consult the patient, but not to dominate the patient. And if the patient closes the door of the hospital, the patient is a free citizen, can go
Yes.
where the patient wants.
Exactly. And it
And
puts you in
that,
a position where you keep secrets from your team because you don't want them to refuse to treat you, but you want to save your own life. And
yeah,
that's
and
not helpful for
and
anyone, for the science,
no,
or for
that's
the patient.
yeah, and that is something which should be more, but much more open. And there are doctors who work very well with us, and there are the others who absolutely do not want to hear it.
Yep.
And that's also one other thing that I feel. I have even went into Europe, into Brussels, in the normal oncology training of residents. In-depth immunology and immunotherapy is not educated, even not now.
Wow.
So, and this is a failure. I think these residents, oncologists in training, they should learn the different aspects of immunotherapy. We have in the pediatric neuro-oncology community, we have such 3 year cycles of courses. You have all molecular biology, radiology, neurosurgery, quality of life, chemotherapy, blah, 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 blah. Immunotherapy, no.
Wow. Even
Wrong.
new students today are not learning that.
And that is, I think immunotherapy and immunology is very difficult. So maybe there is no real fun on immunology, but it should be educated. At least the basic principles should be educated. If they design trials with checkpoint inhibitors together with temozolomide, this is stupid. First of all, during temozolomide, your immune system is weakened. And second, you have not at all any evidence that there is a spontaneous anti-cancer immune response. So what should you modulate with your immunotherapy checkpoint inhibitor? There is nothing to modulate. So such combinations, I don't understand that this comes even into question. I don't understand. And that is because, of course, immunotherapy is a holy grail, and that's a very important, and it was the breakthrough in cancer in 2013. But you should learn what is immunotherapy. There are so many types of immunotherapy, and as I have explained, you have to use your appropriate weapon at an appropriate time point with an appropriate goal. Otherwise,
Yes.
it will not work.
Yes. And it's not one size fits all. Do you talk to patients? This is something that everybody asks me, and I don't know if you care about it or not, but diet at all, or do we stick with medicine?
Yes. So that's part of the metabolic cocktail and part of the gut-brain axis. So there are two domains that have something to do with diet. So too much ketogenic diet is also not good for the immune system. And being in catabolism, losing weight is also not good for the immune system. So that should be looked for. But have good intestinal bacteria, fiber-rich foods, bifidus bacteria, medicinal mushrooms, and all the types of things. I think if the flora in the gut is very good, then the immune system in the brain will also be very good. So yes, we discuss about these things.
Love it. I love it. Yep. So important. Oh my gosh. Well, I don't want to take too much more of your time. I'm so excited to share this with the community. I know everyone's going to be really excited to get this information and to learn about you.